I don't think I was recording. Anyway, I thought I was recording. Huh. All right, well.
Earlier, I don't know if it cut off at some point.
Well, you know what? Remember I told you guys that there was a network issue?
Yes, sir.
I suppose that could have happened. Oh, well.
Did you stop recording after the first break?
You know, that's possible. I don't remember. I don't think I did. Well, I could have. Who knows? Sometimes if you're just not paying attention enough, right? This time is really moving. All right. So make sure you're doing catheter care, cut down on infections. Also, when they're inserting these catheters, for example, they may not insert the catheter or the needle directly into the jugular vein, but they may enter it a little further down to go into the subcutaneous tissue first, and then enter into the jugular vein. And they do that in order to avoid direct infections or bacteria introduced into the jugular vein. So instead of actually going directly into the jugular, you kind of just enter it a little lower. And so the subcutaneous tissue kind of provides a bit of a barrier so that these patients don't develop an infection, because then they have to remove these catheters and put it somewhere else. So anyway, they do this in order to cut down on infection. They typically have two lumens on these dialysis catheters, one for outflow and one for inflow. Blood enters into the dialysis device, and the device actually cleanses and purifies the blood, and then the blood returns back into the body. That's pretty much the process. Now, I told you already, I won't mention this again, I already said this, just basically about this, these caths sometimes have a third port that you can do the blood draws, fluids, and medication. So anyway, the KRT can be intermittent versus continuous. It can also be done at the bedside, especially for critically ill patients. If the patient is critically ill, they'll bring the machine up to the unit and do it at the bedside. Or it can be done at an outpatient site if the patient is pretty stable, lives in the community as well. And the peritoneal dialysis is also considered an intermittent modality as well. So as far as the continuous replacement therapies or hemofiltration system that we just discussed, it is used to remove waste and also restore both the acid base and the fluid and electrolyte balance. And this is what the whole goal of therapy is all about. This is actually a different type of system that they use over a 24-hour period. The one that they, for example, the hemodialysis, where they insert the catheter through the AV fistula, where it's done for about 4 hours, that's a little more harsh on the person's body, and sometimes it's not good for their blood pressure. But when you're in the unit, they may place them on a 24-hour. It's called a CRRT. They may place them on that type of device for patients who cannot tolerate those kind of changes in their blood pressure. So they, as would occur with the intermittent type. It's a more softer kind of hemodialysis type of system. We used to call it CVVH, but now they call it CRRT. No, actually they call it next stage. Now it's called next stage. And it's just a hemodialysis system, but it's more softer on our bodies, if you will. They can tolerate it much better. All right, so this is the one, the CKD. I think what kind of makes this a little long is that have to go into, so we may not break as much at this point. If we do, may take about 5 minutes and come on back, kind of clear your head, so we can kind of get through this. So this is CKD. CKD is a progressive, irreversible disorder wherein the kidney does not recover. The kidney function will not recover. This is also referred to as end-stage kidney disease, or ESKD. These patients develop azotemia, uremia, and also a condition called uremic syndrome. We'll talk about that. As far as the the abnormalities in kidney function that can alter the patient's health, and it is present for at least greater than 3 months, as opposed to your AKI. Your AKI is usually short duration. When the kidney function or waste elimination is too poor to sustain life, again, it can be referred to as CKD or end-stage kidney disease or end-stage renal disease. So take your choice. And of course, there are other terms to describe CKD. There's the azotemia. And what is azotemia? It's the buildup of nitrogen-based waste in the blood. And this is why we have to, when the kidney is not functioning, this waste builds up, causing the patient a lot of problems. Also look at chart 68.2 for signs and symptoms of uremia or azotemia signs and symptoms. Look at that information. These patients also may develop uremia or uremic syndrome, which is a serious complication of CKD and can be of AKI as well. All right. It occurs when the urea and other waste products build up in the body because the kidneys are not able to eliminate these substances. So again, reason why we need our kidneys, right? Also, take a look at page 1391, table 68.1 for the differences between AKI and CKD. I thought I gave you all that before anyway. Well, maybe not. All right, I won't go over this too much, but if you look at table 68.6, just talks about the 5 stages of CKD based on the glomerular filtration rate. So just take a look at that. I told you that the GFR is more accurate. They can do a 3-hour or 24-hour urine collection in order to measure the GFR. Keep in mind also that a patient can have CKD that usually starts with the normal GFR. But these patients, they're still, even though their GFR is fairly normal, they still are at risk for developing kidney damage. Because these patients, they have these abnormal urine findings, or they may have some some problems with the structure of the kidneys, or they could have some genetic issue as well. So in other words, just because the GFR is normal, and these patients, they may be going into CKD. The GFR can be normal, but it doesn't mean that they're not going into chronic renal disease. So just keep an eye on that, especially when you're looking at the urine findings. You may find too many casts and sediments. You may find hematuria. All these different problems with the urine that points to something that's going on that requires further investigation. Now, these patients in category 1 that you'll see on the this GFR chart, a chart or table? When you look at the table, in category 1, they're at increased risk of renal damage from infection, from dehydration, etc. So as a prevention method, we want to cut down on any possibilities of these patients having an infection, which can lead to renal damage. And also dehydration. You want to make sure these patients well hydrated. Again, we are in that prevention, health promotion, disease prevention mode. So the medical team must manage effectively conditions that may cause further damage to the kidneys, such as your diabetes. These patients who are susceptible to CKD, you want to manage the diabetes and the hypertension and the heart failure. In doing so, you may be able to reduce or to prevent these patients from progressing to this full onset of disease, CKD, or you can slow the process at the very least. You may buy them 15, 20 years, who knows? Now in stage 2, because I want you to read the rest of these stages as well. In stage 2, there is an increased urine output of dilute urine. The urine is dilute. The urine output is significant as far as amount, but it's more dilute. And it is because the nephrons are not filtrating the urine like it should. And because of that, these patients are at risk for dehydration. Let's see, where are we? Certainly, all right. So as I've always mentioned to you all, always look at your how systems are impacted by disease processes. And just makes it a whole lot easier for you to understand and also remember what is going on as it relates to the different systems. So when the GFR is greatly reduced in these patients who have CKD, there are many problems that will ensue. These patients have abnormal urine production. They have severe disruption of their fluid and electrolyte balance. And also they have these metabolic abnormalities as well. So they have a lot of problems. The nephrons that are located in the kidneys, when they have to, when they're healthy and a patient will begin to start having kidney issues, these nephrons will become larger because when, in order for them to work harder and continue to do its job, they will become larger. Kind of like your your left ventricle becomes thicker and larger in order to compensate for all that pressure it has to pump against. So your nephrons are pretty much doing the same thing. They're getting larger and they work harder, and this will lead to urine production and water elimination in order to maintain that homeostasis. And this will occur until about 3/4 of our renal function is lost. So it won't last forever. It's kind of a compensatory mechanism, if you will. Now, greater renal disease progression will lead to an inability to produce dilute urine. And of course, this will lead to a more fixed osmolarity, so the osmolarity won't really change. This is as the kidneys are continuing to deteriorate. And so as the renal function continues to decline, these patients, their BUN and their BUN will begin to increase and their urine output will begin to decrease because they're not eliminating at that point. Now, when these patients have extracellular fluid and blood volume that is increased in patients with CKD, because they can't eliminate, it cannot eliminate, and therefore it will lead to fluid overload with edema. These patients will have pulmonary crackles. again, because of the pulmonary edema, which will also lead to shortness of breath or respiratory problems. And some additional information as well is here for you to read. As far as metabolic changes, the creatinine actually comes from protein in skeletal muscle. So the rate of creatinine excretion depends on a patient's muscle mass, their physical activity, and their diet. And so the serum creatinine levels can remain pretty constant when the physical activity and the diet the patient is on does not swing or change significantly. So when it's fairly stable, then if their physical activity is fairly stable and the diet is fairly constant, then your creatinine levels will not be as high. All right, but creatinine does come from the protein that is in your skeletal muscle. Now, your creatinine is partially excreted by the kidney tubules. And as a result, what will happen sometimes is that when a patient has decreased renal function, of course, the creatinine levels will begin to increase. So this is why we have to monitor these creatinine levels pretty frequently. Now, urea is another waste product, and that is made from protein metabolism, and it is also excreted by the kidneys as well. And it does rise when the renal function is also compromised. So this is another waste substance that can poison our system as well when the kidneys are not functioning well. Now, when someone is in early CKD, you may wonder what do the electrolytes look like in the early stages. So in early CKD, the sodium level is increased because there's a lot of sodium loss in the urine. But in late CKD, the sodium level is decreased, and these patients, they're retaining more fluid now. All right, so if you're retaining more fluid, you get a more dilutional effect, and so the sodium appears to be much lower. All right, and so of course, when you retain fluid, these patients, they will develop edema or swelling, as well as hypertension because of all that volume that they're holding on to, that intravascular volume they're holding on to. And you certainly want to be careful about the sodium dilution if that fluid begins to build up, because it can throw off your numbers. Also, make sure you know your normal range for your potassium levels, because in CKD, the potassium level tends to increase. These patients have changes in their cardiac rate and rhythm. You have to also be careful about these patients ingesting drugs that contains potassium, or that can cause the potassium to increase. What may also increase the potassium level is if we don't restrict, and that's why we bring in a dietitian so they can restrict some of the potassium in these patients' foods. So you may have to get them on board too, in order to make sure that they're receiving just enough, but not too much that it would be that it could impact their cardiac system. Also, patients who have increased tissue breakdown, they can have an increase in their potassium as well. So we want to make sure these things do not happen. Now, let's see. See, I talked about that already as far as in CKD, as far as acids and bases. These patients will typically have, they will be in metabolic acidosis. So we know about that already. So I'll let you read that. All right. So, all right. So let me go over this little part with you. we talk about what leads to acidosis in patients with CKD. As far as renal excretion of hydrogen ions, that's the H plus. That signifies acid. All right. Normally, the kidney tubulars cells they move the hydrogen ions into the urine for excretion. All right, and this helps to maintain a more balanced acid and bases in the blood system itself. All right. Now, for this to occur, in order to be able to remove the hydrogen ions from the system, the urinary system or the renal system actually removing the hydrogen ions, for this to occur, there has to be what we call ammonium or NH4 or ammonium and bicarb present. When these substances are present, they help with this movement or removal of the hydrogen ions. Unfortunately, these patients, when they have CKD, ammonium and the reabsorption of bicarb, the HCO3, is non-existent. It doesn't exist. And when these two elements are not present, it will result in an increase in hydrogen ions. Remember, hydrogen ions is your acids. So an increase in hydrogen ions and a decrease in your base will result in a base deficit. In other words, you don't have any base in your blood systems to buffer the acids and bases. And so you end up with more hydrogen ions building up in your blood system, again, because ammonium, NH4, or bicarb, HCO3 is not present. When they're not present, hydrogen ions will increase and these patients will go into metabolic acidosis. Kind of gives you the inner workings of how this comes about. All right. And you can still read that, get an idea of it, and of course, know that you understand what is happening at the molecular level, if you will. All right. And also keep in mind, too, that when someone has an increased potassium level, it does reduce the kidney's production of NH4 and excretion. So it's difficult to excrete ammonium when your potassium levels are really high, which is another reason why we want to get your potassium levels under control. We also talked already about when hydrogen ions increases in the body, you're becoming more acidotic and you breathe a whole lot more. That's a compensatory mechanism. And these patients have Kussmaul respirations. And this type of respirations, it does increase with patients in renal disease that is progressing or getting worse. Let's see, your physician will give these patients an alkali replacement treatment or therapy, and this actually buffers that acidosis. When they're given like bicarb, it tends to move you back into that range of 7.35 to 7.45, which is what you want. Your cells survive better and they function better and more normally between 7.35 to 7.45 in your acids and bases. When they fall in less than 7.35 or greater than 7.45, you either have a depressive impact on the body systems or an excitatory impact on the body systems, which we talked about earlier. So this is why your kidneys are so important. So you're only getting a chance to see how valuable your kidneys are. All right. Also read about calcium, phosphorus, PTH as it relates to CKD on page 1400. As far as cardiac changes, patients with CKD, they usually have hypertension. And of course, hypertension can cause CKD because remember the high pressures, not allowing the kidneys to be perfused. or it can result from CKD. So when the kidneys are destroyed, some of these patients, they will end up with hypertension as a result. Because remember, you're holding on to all this volume now. All right. Let's see. So we talked about CKD that can cause an increase in your blood pressure. So I won't go over that again. This is just talking about the ROS system, so you all can just read that again, because we're kind of talking about the ROS system to death. But I do want to make sure you know it. Now, patients who do have hypertension, it can lead to, hypertension leads to coronary artery damage and also poor coronary perfusion. So this is a good reason why we want to make sure we get these patients better controlled. Take a look at hyperlipidemia and heart failure on page 1401 in your book when you get a chance, as it relates to CKD. As far as pericarditis, also on page 1401, read that as well. We have a pericardium sac that surrounds our heart, and it becomes inflamed. Pericarditis, inflammation of the pericardium, and it is inflamed due to the fact that these patients have uremic toxins. Remember, if you cannot eliminate all these toxins, that poison builds up and it affects the tissues surrounding your heart, hence pericarditis. And so you can take a look at on that page signs and symptoms of pericarditis. Now, as far as hematologic or immunity changes, anemia, you will find that anemia is very common in the latter stages of CKD, which they actually worsen CKD signs and symptoms. So the signs and symptoms actually are worse when someone becomes more anemic. When someone has CKD, they have decreased levels of erythropoietin, which is a hormone that helps to produce red blood cells. When those hormone levels of erythropoietin is decreased, these patients will develop decreased red blood cells. Also, the lifespan of your red blood cells is decreased when the blood has too much that uremia, that poison in your blood system. So your red blood cells, they don't survive very long. When that happens, this results in your iron and your folic, it results in iron and folic acid deficiencies. All right. And they give these patients a drug called Epogen. Some people call it Epogen. And this is a hormone, a synthetic hormone that helps to produce your red blood cells. Remember, your red blood cells are produced from a normal functioning bone marrow, but also from your kidneys as well. Now, as far as GI changes, also read page 1401. Uremia, again, that poison that builds up in your system, uremia from CKD, it can affect the entire GI system. For example, the normal flora of the mouth, it changes when these patients develop uremia. The mouth contains this enzyme called urase, and it functions to break down urea into ammonium. And what happens in these patients with CKD is this ammonia, it generally remains. And it leads to halitosis. And you probably met some people with halitosis, really bad odor, breath odor, and also stomatitis. When these patients have halitosis and especially stomatitis, they cannot the food tastes different. It tastes funny. And so they have a nutritional deficit, become malnourished. And remember, a healthy immune system requires adequate nutrition. If they're not eating like they're supposed to, or adequate nutrition, then their immune system is compromised. I know some of us, or you guys came on a little earlier to do your test and everything. And so at 2 o'clock, if you want to go ahead and break, well, you want to go ahead and leave, you can. The information is on the PowerPoints. Those of you who want to stay, you can as well. I don't want you all to feel that I got you in class early, which I did, and that I'm compelling you to stay until the end. So if you want to leave at 2 o'clock, you can go ahead and do that. Just want to throw that out there. As far as cognitive and functional changes, there is cognitive impairment in a late stage of this disease. These patients can also have an increased systemic drug toxicity risk, because if you're not eliminating the metabolites from these drugs that are broken down that your patients take, they can begin to increase more and more, causing a toxicity in these patients. So this is not really a really great statistical information, but about 25% of your patients receiving treatment for end-stage kidney disease will die in the first year of dialysis. Pretty grim picture. Take a look at page 1401, chart 16.3 of kidney and urinary problems. That is a very important chart for you to read. So please take a read of that. For example, these people need at least 1 or 2 liters of fluids to flush out waste products. This is a prevention more so. They're not quite at the stage where they're not eliminating at all. So you can still prevent further deterioration, right? So water is an ideal flushing agent, as you read here. And they also should have their renal function tests and serum levels of creatinine done periodically to evaluate, to assess their status, see where they are. Diabetes and hypertension are the 2 main causes that leads to a patient having or requiring hemodialysis, and also a need for a transplant. Mostly African Americans are impacted by this. CKD is rising, and it is affecting more older adults. Approximately 11% of Americans do have CKD, by the way. Let's see, also read table 68-7 for causes of CKD. For example, TB, pyelonephritis. I think pyelonephritis was one of your intrinsic or intrarenal types of renal failure. Diabetes, hypertension, glomerulonephritis, etc. So go ahead and read that table for additional information. See, these are slides that I can have you guys read on your own, because they're pretty simple. All right, so this particular slide here, I'm going to have you read it on your own. It just talks about a lot of teaching. All right, so just learn about what things you have to be teaching your patients about. For example, dietary adjustments such as restrictions of sodium and protein, etc. Controlling the disease by managing other comorbid conditions such as diabetes and hypertension. These patients should stop smoking. So this is pretty easy stuff for you guys to read and understand. So go ahead and read that. Pretty easy. Pretty easy. I somehow feel the time getting away from me. Let's see. This is pretty easy to look over as well. As far as a part of our assessment and looking at the history, looking at our weight management, looking at our weight and height management. mostly weight management. It is a comprehensive team approach, an interdisciplinary team approach of dietitians and nurses and mental health specialists, therapists, physicians, and so forth. It requires a team to deal with these health concerns. Know that when you weigh a patient and they are more weight than they were before, that there may be a fluid overload. So look for those signs and symptoms, especially respiratory symptoms and blood pressures and so forth. Conversely, if the patient is losing a lot of weight, it could be due to anorexia, because if you have this uremia and it builds up in your system and it affects your GI system and it causes the food to taste really funny and it's not desirable anymore, these patients won't eat. So they become malnourished. All right. So there are many conditions that does lead to CKD, like your diabetes, lupus, and so forth. Something you all will find interesting, when patients eat certain meats may cause them to have a metallic taste. And this is because of all this poison, this buildup of uremia. This nitrogenous waste, everything is building up in their system and affecting their GI system, even their taste, which is a part of the GI system, obviously. All right. Now, signs and symptoms of excessive waste in the blood, especially uremia, meaning the body cannot eliminate, is nausea, vomiting, diarrhea, also hiccups. All right. And there's some additional symptoms as well there. These patients may have fatigue. Fatigue is common with patients with CKD. Remember the anemia that they develop. And if they're on dialysis, they especially become fatigued, because that is a very harsh therapy on their system. Also, you want to look for some impending pulmonary edema and any kind of neurological degeneration. Signs and symptoms such as weakness, drowsiness, and shortness of breath. All right, I'll let you look at the rest of this. Again, very self-explanatory. These are some of the symptoms that you will see in your patients. And again, we're looking at them by systems. Most signs and symptoms are due to your fluid and electrolyte balance, your acid-base balance, the impact these conditions have on our body systems. It is also due to your buildup of nitrogenous waste. Nitrogenous waste, again, would be things like your ammonia, your urea, uric acid, and your creatinine. That's the nitrogenous waste that I'm talking about. All of these substances are produced from protein metabolism, all right? And so we need our kidneys to eliminate. There's also a condition on here called osteodystrophy. And basically the bone structure, it morphs, it changes shape. And patients with CKD, this is one of the characteristic conditions that you'll see in these patients. It has to do with disease, mineral deposits and whatnot. And look here where it talks about the foul breath, mouth inflammation and ulcerations. Remember the stomatitis and the halitosis in these patients. And other information is pretty self-explanatory. Skin disorders, you may have some bruising and whatnot. I'm going to have you guys read the psychosocial assessment. Remember, this is very important because they do ask you on NCLEX about some of these psychosocial issues as it relates to your patient. So make sure you read this section because these patients are dealing with a very disruptive condition. All right, so read that information as well. You may have to respond to it. For example, anxiety, you may have to refer the patient to a mental health professional. As far as coping styles, again, they may require a mental health specialist to help them with this. Yeah, so take a look at that. Let's see, what is this? All right, so these are some of your laboratory assessment in imaging. Something we looked at in your your AKI, similar tests, but they seem to look at your GFR more so with your CKD. All right. So look at chart 68.1, page 1395 for normal lab value ranges and how CKD can affect them. Early CKD urine tests will show proteins, glucose, red blood cells, white blood cells, etc. But in the latter stages of CKD, you will have a decreased urine output and an osmolarity that is increased as well, because again, the kidneys are not filtrating properly like they're supposed to. We do monitor the GFR trends, remember that. It's a better indicator. When we're talking about the GFR, it estimates the serum creatinine, the age, the gender, the race, and the body size. So it is a more specific tool that can be used to determine how severe the renal status is in these patients, as opposed to just randomly just checking the BUN and creatinine. This is more specific. All right, so keep that in mind. They also use the GFR to determine the amount of drug dose the patient will receive. So if the patient is getting any of these drugs that can be nephrotoxic to the kidneys, then you want to look at the GFR and see how they're functioning, or to see if they are impacted by these drugs. So they use it for that purpose. We talked about the 3-hour and 24-hour urine tests already, where you can do a GFR test. Now, these patients with severe CKD, they will have their serum BUN and creatinine done in order to determine the degree of uremia. The higher the BUN and creatinine, the worse or the more severe the uremia, the poison. Always think poison when you think about uremia. And remember, your creatinine levels are determined by your muscle mass, your diet, as well as activity. All right, as long as they stay stable, your creatinine levels are not increasing significantly. All right, BUN levels are determined by the amount of protein intake. And so if these patients do not have any protein restrictions, the BUN levels will increase. All right, that's when the nitrogenous waste products will begin to increase. The poison, it will begin to increase. Fluid levels can also affect your BUN as well. If you have more of a deficit in your fluid levels, your BUN can also increase. All right. This bone X-ray of the hand can also determine if the patient has renal osteodystrophy, that abnormal shape, if you will, of the hand. An X-ray can show a shrunken kidney, which happens with long-term CKD. The kidneys are smaller. The kidneys are smaller in these patients because of atrophy or fibrosis. So these kidneys are not in good shape by any means. Probably because they're not being used, they're not working. You know what I mean? And there's also a CT, a scan or ultrasound that can view the structures of the kidneys if CKD occurs suddenly. So you may note that there's some structural issues or obstructions that may be contributing to the CKD if it occurs suddenly. An obstruction can cause CKD to occur pretty sudden. So you have to remove the obstruction, obviously. All right, so I'll have you go ahead and read these. These are just some really great nursing diagnoses that are relevant to CKD. All right, so go ahead and read that. Fluid overload, cardiac output, weight loss. Go ahead and read this one as well. Talks about potential for infection, injury, as well as fatigue. Things you might, for example, fatigue due to kidney disease, anemia, reduced energy production. So, I mean, can you all tell me what things you can do to alleviate some of this fatigue?
Possibly frequent rest periods and to rest.
All right, say that again.
Frequent rest periods.
That's what I was thinking.
Too exhausted.
Yeah, that's what I was thinking. Frequent rest periods, you know, that balance of rest and activity. Yeah.
And also planning out your day.
What is that?
Planning out your day.
Yeah. All right.
And then also knowing your limit.
Know the limits. What about the erythropoietin, the hormone? Giving them that drug to increase their red blood cell production. The red blood cells may be red blood cells may be so low they may require a transfusion. Making sure they're eating properly. You know, small frequent feedings. So just begin to think about all these interventions that you can do, that you can come up with. And as you're reading your textbook, be thinking about these interventions that can be done. I hate soft bananas. I think I'm gonna throw that away.
What?
I know. I looked at this banana, and somehow these folks are not eating them. And I decided I didn't want to waste them, so I was going to eat them, and I did one, but I'm not eating the other. They can throw them away. All right. Yeah. So this is another one. This is this is the last one. Just read these. I think they're really nice. They can help you. This one is very important here. Anxiety due to change in health status, economic status, relationships, role function, threat of death, lack of knowledge about diagnostic tests, disease process, treatment, loss of control, or disrupted family life. Do you all see the impact that CKD can have on a person? So in reading this, your those wheels should start turning in your mind. You know, for example, when it talks about lack of knowledge about diagnostic tests, how can we minimize that other than what? Teaching our patients about their diagnostic tests, about their disease process, about their treatment. And we use the teach back method. You teach them and they teach you back, you know, in their own words, which would signify to you that this patient understands what you just taught them. All right. Let's see, what is this? So this is fairly long here too. How much time we got? All right. So I'm going to go ahead and let you all read this information as well. I already have it written out for you. And so we're basically trying to manage the fluid volume, prevent pulmonary edema from fluid overload, increasing the cardiac function. What do? We give afterload reducers, may give even preload reducers. We're enhancing their nutrition, preventing infection, preventing injury, minimizing fatigue, reducing anxiety, and also recognizing and managing depression. So I'll let you go ahead and read this information as well. Pretty straightforward, what I've written here for you. There is a very lovely what do you call it? Concept map in this chapter, by the way. It's really comprehensive, and it will give you an idea of what your concept map should more or less look like. Trying to see if I can find it. You all see it?
1406.
1406.
Yes. But you all read that. Great information. It gives you all the rationales as to why you're doing what you're doing. Like it says, when you're giving morphine, it says monitor the patient's respiratory rate, O2 saturation, blood pressure hourly if given IV morphine. Morphine reduces myocardial oxygen demand by triggering blood vessels to dilate and to provide sedation, and you want to avoid respiratory depression. So there's a lot of really great information in there that I want you all to read about. Let's see, let me look on here to see if there's anything that stands out that I may find that could kind of trick you. Right here where it says expected outcomes for patients with CKD, you're monitoring you want a normal blood pressure, a CVP, which is a central venous pressure. Central venous pressure is a type of measurement we do where we're measuring the fluids in the right atrium, and it gives us an idea about the patient's fluid status, whether they're dehydrated, normal, or they have too much fluid. I think the normal range is between 6 and 8. They usually have to put in like some kind of a central line of sorts. That tip of it falls right into the right atrium, and it just gives us a determination of fluid status. Also, we're looking at as far as the expected outcomes, normal electrolytes, normal body weight that is stable, and doesn't increase between dialysis. You know, with dialysis, you certainly want to make sure you're weighing these patients before and after, because if you weigh them before and they weigh 100 pounds and you weigh them after dialysis and they weigh 20 pounds more, they're probably going to be in overload. All right. These patients with CKD, they require drug treatment, nutrition, fluid restrictions, and hemodialysis once they reach stage 5. Once they reach stage 5, they may require, they will require hemodialysis. And you'll be able to look at these, the glomerular, the GFR, glomerular filtration rate, which is pretty low. When you reach stage 5, I think it's like maybe less than 40 mLs. Well, actually, I'm sorry. It's less than 50 mLs per minute. So you're almost not eliminating any urine in this regard. So if you're not eliminating urine, you're building up toxins in your system. All right, so it talked about hemodialysis, which they do about 3 or 4 hours a day, 3 times a week. Also, as far as peritoneal dialysis, it involves the use of the peritoneum that becomes the dialyzing membrane. All right. And they insert this catheter in the stomach into the peritoneum. And this is where the dialysate fluids, it bathes that peritoneum. And you have this exchange of fluids, electrolytes, and so forth and so on. And you have some additional information that we can cover in more detail. As far as fluid management, nothing really stands out. So go ahead and read that information as well. Look at these interventions now. Other management activities for fluid overload: daily weight, intake and output, monitor weight before and after dialysis, observe fluid restriction. See, really easy stuff. Nothing complicated. You want to, as far as fluid intake, you're looking at types of fluids or intake, oral, whether they IV, enteral sources, etc. So know what is considered intake and what is considered output. If somebody's on a 24-hour urine fluid restriction, if they're on a 24-hour, on a fluid restriction, you want to give most of the fluids during the daytime. And as night approaches, you're giving less. You know, when you're sleeping and you're really tired, even if you're thirsty, you can continue to sleep for the most part. But if you're wide awake and now you're thinking about it, and if you don't give these patients anything to drink and they start drinking at nighttime, they can be pretty miserable. So just make sure you're giving them most of those fluids. But you want to spread the fluids out over the 24-hour period, but make sure most of it is being given and during the daytime hours. That's my point. Let's see. Of course, we talk about preventing pulmonary edema. Go ahead and read that as well. I talk about here signs and symptoms of pulmonary edema, early indicators, which is restlessness, anxiety, increased heart rate, shortness of breath, crackles, breath sounds at the lung bases. You should always know what your early signs and symptoms are, because what good does it do the patient if you're always catching signs and symptoms in the late stage? Because usually part of the late stage is death. So you want to catch the early signs and symptoms. Let's see, so you read about your treatments. Treatments, for example, for pulmonary edema, acute hospitalization, which is obvious, O2, high Fowler's position, loop diuretics are used to treat PE, all right? So all this is self-explanatory, so I don't have to really go over a lot of this. Your IV morphine must be given also to decrease myocardial oxygen demand. And the way it does this is the morphine dilates your arterial system. It causes vasodilation, and the heart has to pump against less pressure. And if the heart has to pump against less pressure, it means it's working less, which means that its oxygen demand is much lower. You want a much lower oxygen demand. You don't want the heart to work so hard to where it requires more oxygen. All right, you don't want to do that. Nitroglycerin, nitro IV is also given to decrease the pulmonary pressure from the left heart failure. And again, this nitro also dilates the blood vessel. So what they might do is a combination of IV morphine, which is your preload, afterload reducer. They may give you Lasix, which is your preload reducer, and nitro, which is your preload reducer, afterload reducer as well. And you want to watch all these combination of drugs because all of them together can cause severe hypotension. All right. Now, when the respiratory function worsens, these patients may ultimately have to be intubated. So go ahead and read about that as well. Read about the cardiac function. Let me change that. Let's see. Talk about here, ACE inhibitors are best drug to decrease these patients from having a cardiovascular event, especially with patients who have CKD, a history of CKD and hypertension. Your ACE inhibitor is one of the best medications to use. Calcium channel blockers can improve your GFR rate, which will enable more adequate blood flow to your kidneys. Teach your patients to monitor their blood pressures daily, and keep a record. Recheck for accuracy, of course. And there's a relationship between adequate blood pressure control, diet, and drug therapy. So all those together can lead to better control. As far as nutrition, go ahead and read that as well. One of the biggest things is making sure that these patients don't have too much protein, because too much protein causes too much stress on your kidneys. So read that as well. I also have here written, read pages 1408 to 1411 for the following: preventing infection. I didn't write the rest of these. Preventing infection, preventing injury, minimizing fatigue, reducing anxiety, and recognizing and managing stress and depression. Just go ahead and read that. Pretty easy read as well. All right. right, so now we get into the KRT replacement therapies, and we have almost 30 minutes to get through some of this. All right. How much is it in here? It's not that many slides, actually. 1, 2, 3, 4, 5, 6, 7. Because when you get to kidney transplantation, I have a voiceover starting at that point, so we don't have to go over slide 31 and slide 31 and forward. We don't have to hit that, but 24 to 30 is what we're looking at. So let me see if there's anything that stands out here. So kidney replacement therapy is required for stage 4 and 5 as toxins are more life-threatening at this point. And this is also when diet, drugs, and fluid restrictions are ineffective. So in other words, we've done the more conservative therapies. Now we need to go to KRT. Hemodialysis is the most common one that is used. And so what does dialysis do? It removes excessive amount of fluids and waste products, and it restores our fluid and electrolyte balance. It involves passing blood through an artificial semi-permeable membrane to do the same job that kidneys do. Because our kidneys normally do normal functions such as filtering and excretion of, or it has excretory functions as well. Complications from hemodialysis, hemolysis, meaning that your red blood cells are bursting, air embolism, dialysate errors, maybe there's something wrong with the dialysate fluid. There's also contamination of this fluid and exsanguination. When we talk about exsanguination, if you don't cap those dialysis catheters off like you're supposed to, they can bleed out. That's exsanguination, bleeding out. Hemodialysis is also indicated for patients if their pH is less than 7.2. Remember, because the kidneys are not doing what they're supposed to do. In other words, excreting hydrogen ions. So we're retaining hydrogen ions. So this patient is becoming more acidotic. The base or the bicarb you're giving them, they're not responding to this. So they don't respond to treatments. The patient experiences fluid overload. They're not responding to diuretics. They develop pulmonary edema, pericarditis. Their potassium levels obviously are increasing, and they develop these EKG changes. Also, there's a condition called calciphylaxis. This is thrombosis and skin necrosis seen in stage 5 CKD. All these patients may develop toxins toxin ingestion as they take these drugs that can be dialyzed out. So if they have an OD or they have poisoning or some kind of poisoning for whatever reason, then this is an indication for hemodialysis. Because dialysis can dialyze these drugs, this poison out of the system. All right, these are just reasons why we have to do dialysis. Sometimes hemodialysis is started when uremic symptoms are present, such as intractable. When we talk about intractable, we're talking about something that is unrelieved. Intractable pain, intractable nausea, vomiting is unrelieved even by medications. So these patients may develop uremic symptoms such as intractable nausea, vomiting, confusion, seizures, severe bleeding from platelets, dysfunction. So they may require dialysis at this time. The length of time for dialysis depends on the patient's age, the cause of CKD, comorbidities such as cardiovascular disease, as well as diabetes. All right. Let's see what else. Most of your dialysis is performed in community settings. Also, it can be done in the home if there's no complications, but it can also be done in the hospital. All right, as far as the procedure for dialysis, how does dialysis work? Hemodialysis works by this process of diffusion. That is, molecules are moving from an area of higher concentration. For those of you who've had chemistry and whatnot, maybe biology. So these molecules are moving from the areas of higher concentration to lower. The larger molecules, now they cannot pass through these membranes. These patients, when they have this dialysate fluid, dialysate is actually the dialyzing fluid that is actually used. And this fluid, it contains a mixture of electrolytes as well as water, and it does resemble the same plasma, human plasma. It's almost just like ours, and that's why it's so effective. So the patient's blood consists of nitrogen or nitrogenous waste products, excessive amount of water, and an excessive amount of electrolytes. And so they use this particular device along with diffusion and osmosis to remove excessive amount of water and also electrolytes to get the patient in a more homeostatic position. All right, so during hemodialysis, these waste products, they move from the patient's blood and into the dialysate. And this happens because of their difference in concentration. So we talk about diffusion in this regard. Now, water is removed from a process called osmosis. I realize that some of you probably didn't have chemistry, but these are processes that we talk about when we talk about movement of water and also particles. We talk about moving from areas of high concentration to low concentration and so forth. So it can be a little confusing, but don't sweat it too much. At some point, you have to take chemistry anyway, especially as you finish up your undergrad. So electrolytes can move in either direction. They also are able to remove a volume. Volume is removed from plasma, and they do this by applying positive and negative pressure within that system, that dialysis system itself. So all this is just to say that this is how we remove it's the dialysis machine, and that dialysate fluid is acting just like your kidneys do. It's that filtration, it's that diffusion, it's that osmotic process that removes excessive amount of fluids, regulates your electrolytes, and so forth. So that's all it's basically doing. This dialysate, it is made of water, chemicals, and it is free of waste products or drugs. This dialysis device, it does have a built-in safety features. I'm not a dialysis nurse, but it does have built-in safety features. As far as anticoagulation, they use heparin. Heparin will stop the blood from clotting because the blood can clot as it continues to move through these systems. So heparin will prevent that. If a patient has too much heparin and they're starting to bleed, there's a reversing agent or an antidote called protamine. And also heparin, whenever it is administered in the body, it is active in the body for 4 to 6 hours after hemodialysis. For this reason, because it is active and it causes the blood not to clot, these patients are at risk of hemorrhaging or bleeding during and after hemodialysis. So you want to make sure that you do no invasive procedures not even, excuse me, rectal thermometers and what have you. No IV sticks, nothing like that. So until the 4 to 6 hours has expired. As far as hemodialysis vascular devices, this device requires availability of high blood flow for a period of 3 to 4 hours of hemodialysis. This is the difference between a hemodialysis vascular access device and some regular looking device. The vascular access device, they can withstand the high flow of blood especially from the arterial system. And it has to be able to do that for that 3 to 4 hours of dialysis treatment each time. So this is why we use these devices instead. There are 2 long-term devices, the AV fistula and the AV graft. The AV fistula is more preferable, they last longer, they're much more tougher. So with the AV fistula, it surgically connects an artery and a vein. And as far as the vessels that they mostly use will be the radial, the brachial, and the cephalic vein of the non-dominant arm. All right. Now, after the AV fistula is created, you can't use them right away. So they'll put in a temporary catheter instead. So time is needed for the fistula to heal and also mature. All right. The increased pressure from the arterial blood flow that flows into the veins, they will cause the walls of these blood vessels to thicken and become more tougher. This is while the dialysis of the AV fistula is healing over a period of time. All that pressure just causes it to thicken up and become more tougher. All right, and this basically leads to a vasculature that is tougher, is stronger, is more durable, and so that's why you can repeatedly do cannulations, or you can insert needles into this fistula for dialysis as they're having to be dialyzed every other day, every Monday, Wednesday, Friday, every Tuesday, Thursday, Saturday. So you can continue to access or insert the needle into the AV fistula, because now it's much more, the skin is more tougher. The blood vessels, they're much more tougher because of all that high pressure. All right. Now, for some fistulas, they may take up to about 4 months before you can actually use them. So again, they will use a temporary kind of catheter. So keep that in mind. During this process of dialysis, one needle is inserted in the venous end, and the other is inserted through the arterial end of hemodialysis. So again, so you can cleanse the blood. Sometimes they will use an AV graft when the AV fistula does not they will use an AV graft, remember, because there's an AV graft, there's an AV fistula as well. But the reason they will use an AV graft, which they don't last as long, they're not as tough or durable as the AV fistula, they might use it when the AV fistula doesn't develop, all right? It doesn't mature like it's supposed to, so you can use them. Well, if there's some kind of complications with the AV fistula, you have to use an AV graft instead. But you would normally use an AV graft in your older patients as opposed to the younger ones. So, all right. Now, an AV fistula is a direct connection between the patient's artery and one of their nearby veins. That's how it's set up structurally. Now, the AV graft is also sometimes called a bridge graft. It is an indirect connection between your artery and the vein. And most commonly, it's a plastic tube that is used. So again, they're not as durable as your AV fistulas. Let's see, what else I'm going to tell you here. when a patient does have an AV fistula, you want to make sure you check their distal pulses. You want to check the capillary refill because you don't want their circulation to be compromised. You can also take your when you take your hand or your fingers and you place them over the AV fistula in these patients, it'll feel like you're touching electricity, which is what we call a thrill. And you can also take your stethoscope and place your stethoscope over the AV fistula, and you will hear what we call a bruit. So you're auscultating a bruit, but you're palpating for a thrill. All right. And this indicates that the system is working. Very important for you to read page 1415, chart 60H7 for patients with an AV fistula or graft. For example, these patients should not have a blood pressure or venipunctures in the arm where the fistula and the graft is located. All right. Hold just a moment, please. All right. Sorry about that, folks. So just make sure you read that chart. It tells you the do's and don'ts as it relates to the AV fistula. In the hospital, they may have a sign placed over the patient's bed that says no IV sticks, no blood pressures, and what have you. Same thing that they might do with a woman who had a mastectomy, maybe on the left arm, and they may put a sign up like that. I think in nursing homes, you can't do that because of HIPAA, but in hospitals, they do. Go figure. Complications from hemodialysis include thrombosis or stenosis, infection, aneurysm formation, ischemia, or heart failure. All right, so these are complications you need to look for in your patients. Also look at table 68-11, page 14 and 15 for interventions to prevent problems with hemodialysis. For example, to prevent clotting, you want to avoid constrictive devices such as a BP cuff and also tourniquets. Most common complication is thrombosis or clotting of the AV access device. And most grafts fail due to the high pressure from the arterial flow entering into the venous system, because it goes from the arterial to the venous system, just like your body does. It goes from the arterial system, and then it goes back to the venous system and returns to the right side of the heart. So same kind of concept or principle. And then you might use TPA, which I provided a definition of that here for you. So just read that as well. So it's just an enzyme that breaks up clots. Staphylococcus is the most common organism found in these patients. They become infected. Well, this is the organism that causes most of the infections, is what I'm saying. There's another complication called Steele syndrome. And what does it mean? When ischemia occurs from fistulas, which decrease arterial blood flow to areas below the fistula, these patients will develop signs and symptoms such as cold or numbness of the fingers that may ultimately result in gangrene. So there's decreased arterial blood flow that can lead to this mishap or complication. Other complications to look for, to watch for, is hypotension, and also a condition called dialysis disequilibrium syndrome. These patients may also develop cardiac events and also reactions to the dialyzer as well. Your dialysis disequilibrium syndrome As far as signs and symptoms are concerned, these patients will develop nausea, vomiting, headache, fatigue, and also restlessness. And this is due to, you can prevent this rather, by reducing the amount of blood flow at the onset of these symptoms. If the dialysis nurse in particular notices that these symptoms are developing, if they just slow down the blood flow, they can prevent this syndrome from occurring. As far as cardiac events, these patients can develop left ventricular hypertrophy and some additional cardiac problems I want you to read about. As far as pericardial disease, you want to assess for pericardial friction rub before these patients have their dialysis treatment. And it does sound like a rub. You can almost hear it even without your stethoscope. And just read page 1417 for some additional complications. These patients may also have, I talked about, it takes a while for the AV fistula to heal. So they may have a temporary vascular device. These temporary catheters are placed in the subclavian area, the internal jugular, well, the subclavian, the internal jugular, may even place it in the femoral vein. The problem with these is that these lumens, the openings for these devices are kind of small. They're really pretty small as compared to your AV fistulas. And so more time is needed to complete the dialysis process. It may take about 4 to 8 hours as opposed to 3 to 4 hours. So these catheters are much smaller. So as far as nursing care, this is very important for you all to know. Some drugs are dialyzable. In other words, they can be easily removed from the blood. Some of the medications you have to give your patients in the morning before they go and have their treatment. And for this reason, you don't want to give this patient, let's say, some of their, any drug that they really need. And then when they go to dialysis, it's dialyzed out. So you can call the dialysis nurse, or there may be a list of drugs that you know that, and you can also talk to your doctor as well. They can tell you what drugs to hold. It should be listed in the electronic medical record as well, telling you to hold X, Y, Z. All right. And then once the patient comes back, they can give it to them afterwards. So look on page 1416, table 68-12 for examples of drugs that are dialyzable out of the system. And so that might be a good list for you to keep somewhere, especially when you go into the clinical setting. Take a picture of it on your phone or something. Now, you also may want to contact the hemodialysis nurse to see if antihypertensive drugs need to be held, especially the ones that can cause hypotension during dialysis. So that may be one of the medications you have to hold. Also, when these patients are having dialysis, you may want to think about some diversional activities so that they can not have to think about what they're doing, such as reading. They can also be a lot of health teaching during this time also. As far as post-dialysis care, common problems after dialysis, hypotension, headache, nausea, vomiting, dizziness, and also muscle cramps. So you want to watch for those symptoms. You want to also compare their pre and post dialysis weight, vital signs, etc. Normal saline may be given for hypotension episodes. The temperature can be elevated, and this is possibly due to when the patient's blood goes through the machine, it actually warms the blood, makes it more comfortable as it enters the patient's body again. So it does slightly warm the patient's blood, so they may have a fever. If they do, the patient might have to have cultures, blood cultures for possible sepsis, just in case. If heparin or citrate is used, if these are blood thinners, I talked to you about no invasive procedures should be due 4 to 6 hours after the hemodialysis. You want to also monitor for bleeding during hemodialysis and 1 hour after hemodialysis. What? wonder that looked crazy to me. I had here, patent. I said to keep lines patient, nurses should prime access device with heparin, normal saline, but it's not patient, it's patent. So to keep lines patent or open, these dialysis devices are primed with some heparin or normal saline so they don't clot off, and you can use it over and over and over again. So take care of your lines. Let's see, what else? So I'm going to have you guys read about peritoneal dialysis. I tell you the truth, I may have to end up doing a voiceover for this particular one, not only for your class, but for future classes, because acute renal failure and CKD, it takes a long time to cover, let me tell you. It's a lot of information. All right, so I'm gonna have you guys read over the peritoneal dialysis. Let's see, that one is long. Well, there's quite a bit on that page. This one doesn't have much in the way of information. This one doesn't have, these are just examples of a variety of dialysis or systems. This one also doesn't have much. There's not a lot on this one. These are just complications of peritoneal dialysis. There's not a lot on this one either. So it's not really a whole lot that you guys have to go over, but I still may end up doing one just to be on the safe side. But just read what I have. And if you have any questions or concerns, just go ahead and let me know. Nursing care during in-hospital peritoneal dialysis. So before treatment, evaluate baseline vitals. Yeah, so you all can go ahead and read that. Pretty self-explanatory. They talk about the well. Now, you have the inflow as far as your peritoneal dialysis, and then that fluid is, as far as, the fluid is to remain in the peritoneal cavity for a certain period of time. And after that time has expired, and then you outflow. So it's inflow, it's dwelling, and then outflow. All right. So if I did do one, so I went over this. Yeah, I think I'm gonna go ahead and just do a voiceover for this section, and I'll let you know when it's already up. And you can listen to the rest of it, or you can read the rest of it. It's up to you. The thing with the live courses and also the voiceovers that there may be some commentary provided to kind of clear up some things. So that's kind of the advantage of that. Also, no, don't do that. All right, that's it for now. I need to look at this test again to make sure. Let me see something. Make sure. All right. Here's what I was kind of conflicted about. As you keep scrolling through, right here, I want you to read pages 1382 to 1384. It's not really complicated. It's not really a whole lot. It just talks about hydronephrosis and urethral stricture. So go ahead and read that information as well, because I might have a few test questions for you on that also. But with my focus areas, I'll let you know in particular, but just make sure you read that section as well. How do you all feel about this information?
It's a lot.
It is, yeah. Now I did the transplant on voiceover, but I'm thinking I should have probably did the kidney the renal replacement therapies as well. And that way I don't have to feel like I don't have to feel the anxiety of trying to get everything in. So I have just found out and come to the conclusion that that CKD AKI is long enough. So yeah, I'll go ahead and create a PowerPoint. It shouldn't be that long, but it will enable me to just spend a little more time. All right.
Just
And say again.
just send me the answer.
It's too many. It's too many. What now?
I said just send me to the test.
I'll send you the answers. You know I can't do that.
I know.
Well, I mean, you all didn't really do bad. I promise you. So, yeah. So I'll get your focus areas to you. But yeah, make sure you all read these chapters here, and it's in the PowerPoint too. So you shouldn't miss this. Let's see. What else can I tell you? Those of you who did not fare or did not reach the minimum on this exam, I'll be sending you an email out so we can meet and discuss your test. We can go over some of these test items. I tell you, for the sake of time, I may just go over the whole thing with everybody just so that people will know what's what. I'll make a decision on that, but at least we'll give you all an idea. So this will be a quiz that takes place next week sometime. During our clinical Monday and Tuesday, we can still kind of go over some of this. We may even go through. I may see if Professor Wittenkeller can go over this this concept map for CKD one of those days, maybe Monday or Tuesday. I won't be able to do it Monday, but Tuesday for sure. And that'll kind of just really get you guys prepared. Can you guys think of anything else?